Hello, I'm Ben. I'm one of the intensive care consultants on 6A. I'm going to be talking to you hopefully pretty briefly about our retrieval and transfer equipment and bags. What I'm going to do is show you the system we have, what's in them and how we check them. So when you're up on 6A, what you'll notice is we have a blue bag retrieval system. There's one that's marked 6A on it that is always sort of available in the foyer of the unit. You also find these bags on the intensive care units downstairs, and we have two slightly modified ones for our ECMO service, which can come in and be used if this one's being used on another transfer. So the primary purpose of these bags is not actually for cardiac arrest and resuscitation, but it is for transfer. It's for transfer of a patient to another hospital, to the CT scanner, to theatre. However, some of our cardiac arrests are quite complex in this hospital. They may involve chest opening, they may involve quite a lot that needs to be done before being transferred to other areas in the hospital. So one of these bags will appear at every cardiac arrest. Now, we're in funny COVID times at the moment, so the 6A bag is deemed sort of COVID's blue or dirty, so it would normally be taken to cardiac arrest. It's not being taken to cardiac arrest at the moment. The blue bag that is the one from the first floor, and a nurse or HCA will be tasked with a cardiac arrest bleep and will go to every cardiac arrest with one of these blue bags. So if you go to an arrest, one of these should turn up. However, if it is a simple cardiac arrest, we should try not to use these because these are the more advanced equipment, and the anaesthetic reg on the first floor will attend the cardiac arrest with a grab bag of simple ALS equipment and a drugs bag. So really, unless it's complex, we should try and avoid opening this if at all possible. The other bag that goes nicely colour coordinated is the drugs bag, and these are kept in the fridges, and there's several in the fridge on 6A and also on the first floor as well. Colour coded except with the bright yellow, and that's to remind you that it shouldn't stay out because it's got drugs like rocuronium that need to go in the fridge. And again, one of these will come with the blue bag to a cardiac arrest. So what is in the bags? So that you may have seen them in other hospitals and departments. It's kind of a pan-London initiative. However, we have modified them specifically for the purposes of Barts. So there'll be a red tag, hopefully, on the top. And when you undo the red tag and open up the bag, what you'll see is everything kind of is reasonably self-explanatory with an ABC system and the added extras. So if we start with airway, and it says advanced airway, and effectively this will allow you to intubate a patient. It's got all the ET tubes, a wide selection. It's got a selection of laryngoscopes. It's got a McCoy's blade if you have a potential difficult intubation, and you can remember what a McCoy's is. You have the ability to do surgical airway, and there are two options with that. We have forceps, the tracheal dilators, but we also have a tracheal hook. If you haven't used those before, clearly doing your first surgical airway is not the time to use them for the first time, but it's well worth opening up, having a look at a hook and deciding what you would use. It's got the adjuncts like bougies, it's got simple airway. So this will allow you to get to the stage of putting a tube down in just about any situation. So you even got a head torch just in case you're doing it in the dark, although you're probably in a lot of trouble if you're doing it in the dark. Then you've got breathing. And this is the next stage from once you've got that ET tube in. And this has the all-important water circuit. It's got face masks in case you have an accidental extubation. And it's got your airway sort of supraglottic rescue devices. So it's got a selection of LMAs. It's got a stethoscope. It's got your circuit. You're never going to open the A and not open the B if you intubate someone. It's just got all the adjuncts for the next stage. And you'll notice on all of them, they've got a checklist at the front that tells you exactly what's in each one. And this is the kind of the massive one, which is circulation. This is effectively a small intensive care unit in a bag. It's the one not to go into for just a cannula because it is the worst one to check by a country mile because there's so many things inside it. I'm going to open it because it hasn't got a see-through thing in it, and it does have some loose bits. But this effectively is your circulation bag, and as well as just about any permutation of cannula you could possibly want, it will allow you to put in an arterial line. It's got a central line. You can put up a pressure transducer set. You can sort of suture things to your heart's content. So it's basically got all the bits and pieces you need for running infusions, lines, invasive monitoring. And again, you don't want to open this just to take one little thing out, because most of the time everything here is available on the wards. And then those are the main three: the airway, breathing, circulation. Then there are two little pouches. One is called self-ventilation. This is for the spontaneously breathing patient. You might be escorting to CT, and it basically allows you just first line airway management of someone that's breathing spontaneously. So it's non-rebreathe masks. It's got a nebulizer for someone that you may need to nebulize, and it's got a set of sort of oropharyngeal or nasopharyngeal airways and some oxygen tubing. So you shouldn't need that very often. And then suction, it's suction spares. You need to take your own suction unit. There's no suction unit in the bag, but in there it has the ability to replace suction tubing if it's getting blocked up. It's got a selection of suction catheters for various sizes of endotracheal tube and a couple of spare Yanker suckers there as well. Then the last thing in the bag is the rather exciting portable capnography and SATS monitor. So these devices are really your backup, and actually, you know, you're not going to need this in an ITU situation or a theatre situation or a cath lab situation, because they have capnography available. But if you go to a ward cardiac arrest that's going on for some time, if you're called to an arrest in the foyer of Bart's, where you're nowhere near medical equipment, our basic monitoring that will arrive will not allow you to do any capnography, and this will pretty instantly. So it's really, really simple to use. There is a simple on button which you press, you wait, it takes a reasonable amount of time to load up, and in fact when you're doing your checks every day, you need to put it on and wait for the screen to load up so you can have a look at the battery icon. There's a simple battery release underneath, and we have loads of spare batteries constantly on charge. So if the battery is low, and I don't know if you can see, but in the top right of the screen it's full with green bars. If the battery is low, then you simply take out the battery, go to our technician's room on 6A and take a fully charged battery. So really the main purpose for this is capnography. On the side there's a little flap that opens up. It takes the orange screw tips for capnography, and in it goes, and that's it, and it starts immediately. That's all you need to do for your end-tidal capnography. It does come with a bonus SATS monitor, which you shouldn't really need because you always have it on other monitoring, but should you wish to have another SATS monitoring on the other side, it's got a special adapter. This will only work with this system, and you can attach that, and then you've got your SATS monitoring as well. So that can be quite useful, especially in the ward or the remote location arrests that you go to that are prolonged. And then when you finish doing your checks, or you finish with it, switch it off and back it goes into the bag. That's pretty much everything in the bag. There are two other compartments. One on this side is just your emergency bag valve mask, for when you haven't got a gas supply for your water circuit and you just need something quickly, and that will always be there. And then finally there is a section at the end where you can carry patient-specific items, medications, and we tend to just keep spare tags for our daily checks in it. So the blue bag, when it arrives for a cardiac arrest, will be brought on a trolley. If you are taking this blue bag on a retrieval or a transfer, just be aware that they've put these little straps at the back, which are there to tempt you into thinking that it's a backpack and you can wear it on your back. However, it weighs the same as a medium-sized child, and so we don't carry these on our backs. So you should always take it on a trolley so that we don't sort of permanently injure you. So those are the blue bags, and then the accompaniment for those are the drugs bags. And these, again, are very self-explanatory. They have a list and an expiry date set on the front. This is not your kind of panacea of all drugs you're going to need for every occasion. However, what this will do is provide you all your emergency drugs. It's got your resuscitation drugs. It's got your ability to deal with an asthma attack, with an anaphylaxis. It's got some bicarb in there, some glucose. So your ALS stock of emergency drugs. These live in the fridge. They're tagged. And if we open them up, you can see they're kind of purpose designed for the vials all to be stuck in with a couple of loose things. It's also got your fluid. We don't have any fluid in these bags because it's deemed a pharmacy item, and therefore we don't leave it out and about, because these bags are left out and about. So you always find these bags in the fridges in the intensive care units. They should always be tagged, and if you use anything, you need to replace it. So that's effectively what we've got in terms of the kit and the equipment. So the last thing to talk about is how we check them, because obviously they're only as good as the last time they were checked, and what you don't want to do is be in the back of an ambulance and open your emergency airway to discover an IOU note or something missing. So what we do is we have a very simple system. Every morning, the short day SHO or fellow on 6A is responsible for a very simple check. Okay, you should always find that the blue bag has a simple red tag on the main compartment, and all you need to do is take that tag off, open up the bag, and then you go through each compartment just checking they've got a red tag. And if they have a red tag, that's all you need to do. Okay. The only other thing is to take out the capnography machine, and like I showed you earlier on, just switch it on and check the battery. And if the battery's okay on this and all of the things have red tags, you don't need to do anything else. You just put your initials on a checklist that will be with the bag and put another red tag on the bag, and it's good to go. Okay, that is literally it in terms of the checks and what we ask for. Now, clearly, if there's things going on, there's emergencies, there's patients being admitted, that takes precedence, but it's your responsibility to hand over for someone else to just do that check for the day, okay, or to delegate that responsibility. That's pretty much it. If you use items from the bag, what you'll find in the top here is there's a checklist of all the equipment and what's in each of the compartments. The reason that is there is it's completely acknowledged that if you're in a complex cardiac arrest, someone's chest's open, they're going to theatre, you may not want to come back at 4 in the morning and immediately go through everything you've used, and that is understood, and you're probably not the right person to go through everything at that time. However, if you could take 2 minutes just to mark what you think you've used, it saves an enormous amount of time for the oncoming day team when they go through the checklist. So if you're a short day SHO and you open this pack and one of these compartments doesn't have a red tag, unfortunately that does mean it needs checking. Okay, it's not just down to you, it's about the team. It should be one of the day's jobs. So when you're allocating who does what, you can allocate who's going to go through the bag and restock it. You're not going to know where everything is. You're going to waste a lot of time trying to find it. So engage the nursing staff, be kind and courteous, and they will help you restock it. That's pretty much about it. The last thing I would say is that the nursing staff and the HCAs bring these bags to the arrests out of enthusiasm and sort of team spirit. It's not in their job plan. They're not responsible for packing, for checking, and we should be very courteous to them when they bring it. Do not expect them to know what everything is in the bag, and don't expect them to be responsible if you don't find what is in the bag. I hope that makes sense. Welcome once again, and I'll finish there. Thank you.